Good afternoon, everybody, and thank you for joining us for the launch of our responses to Mpox in Ireland report. My name is Adam Shanley. I'm the Empower Programme Manager here at HIV Ireland, and I'm very grateful that you're all sharing your lunchtime with us, or if you're watching after the fact, that you're taking the time to watch back. So you're all very welcome. So look, as I'm sure you're all aware, the 2022 global outbreak of Mpox presented significant challenges for gay, bisexual, and other men who have sex with men. And at Empower, we're really committed to understanding and adapting to changing and emerging needs of our community. So with that in mind, during the outbreak, the Empower programme at HIV Ireland, in collaboration with colleagues at the University of Galway and the University College Dublin, with funding from the HSE and oversight from a community research advisory group, we conducted a nationwide survey among GBMSM in Ireland to better understand the views and experiences of our community during that public health emergency of international concern. And we'll hear the findings and recommendations from the research team shortly. But first of all, I just want to take the opportunity to note that while we're likely to kind of speak in the past tense over the next kind of 45 or 50 minutes, it's important to note that Mpox isn't over. The report, it focuses on the outbreak phase, and so we'll be looking back. However, people continue to acquire Mpox, and we're still seeing a small but persistent number of cases globally, and particularly in countries that haven't been afforded access to vaccine at all, and that have decades-long outbreaks in some cases. So the point being, I suppose, is as long as new cases occur, the potential for new outbreaks remain. In fact, we saw a small cluster of cases in Ireland towards the end of the summer. So and many of those who acquired Mpox weren't vaccinated. So I know I may be preaching to the converted on this call if you've tuned in, but if your friends, if your partners, your hookups haven't yet been vaccinated, it really is a good time to encourage them to go and get vaccinated. Sexual health services in Dublin are still offering the vaccine free of charge, but as far as I'm aware, it is only available in Dublin, and so I think equity of access may be something, a topic for discussion during today's event, but we do know that the HSE is working on improving that access, and we do continue to update the Mpox pages on the Empower website as well, so you can find out more details there. Anyway, we'll kick off in a moment's time with a presentation of the findings from David Comer, and then following that, Dr. Chris Noon and Dr. John Gilmore will join us for a discussion. If you're joining us live on Facebook or on YouTube, please use the comment section and the chat box to submit any comments or questions that you have, because we'll have time at the end to kind of put it to the panel. The full report is now available on the Empower website. So if you go to our website, empower.hivireland.ie, under the research tab, we have it there. And we'll also have a limited number of printed copies available. So if anybody wanted one of them, you can just drop me an email. So it's with great pleasure to introduce David Comer. He is a PhD scholar on the Sphere programme at the University of Galway. We've been incredibly lucky this year to have David join the Empower team on his PhD placement. He has been working on a really comprehensive analysis of our programme data. So watch out for an Empower impact report that we'll release before the end of the year, and that David's put really great care and attention into. So we're very excited about that. But equally as important is David's input into this Mpox research, that he's going to present the findings on for us now. So David, the floor is yours.
Hi everyone, I'll just share my slides now. You see that okay?
Yeah, perfect. We can see that.
Perfect. Okay. As Adam said, I'm a PhD student in the University of Galway. My name is David, and I'll have you for 20 minutes or so, giving an overview of how we did this research, but then with primarily a focus on the results and then recommendations that we're making following our findings. So obviously I did this with John Gilmore and Chris Noon, who you'll be hearing from in a little while as well. So just a brief background, as Adam said, and as I'm sure you're all aware, the World Health Organization declared a public health emergency of international concern in response to Mpox last July. And while that was an international outbreak, west of Europe, including Ireland, was considered an area that was particularly high risk for this outbreak. So it's something that we really need to pay close attention to. As a bit of background, Mpox is transmitted through close physical contact with someone who has been affected.
David, I'm sorry there. We actually can't hear you properly. I don't know if your headset or your phones aren't connected properly.
Is that better?
That's better. Yeah. Okay. I don't know if it's maybe when you're moving, it might be the connection.
Perhaps, yeah. Cool. So Ireland first reported a case of Mpox on the 27th of May, and then there was an internationally introduced smallpox vaccine that was approved for administration, but there was very significant limitations on supply of that vaccine. So in Ireland, when we began delivering that vaccine, we prioritised particular groups that were deemed most at risk. So in Ireland, that would have been people who had a recent diagnosis of early infection syphilis and other conditions like that. So the HSE established a national crisis management team that included LGBT organisation reps, so Empower and Man to Man, and those community organisations were, I suppose, responsible for leading that community-focused communication on Mpox. So from the beginning, there was this idea that we needed to have a direct line of communication with people particularly affected, and that, as you know, included.
Sorry, David. Me again. It's just it's popping in and out again.
I might just try disconnecting my headphones.
Yeah, maybe that might work.
Is that better? Can you hear me now?
Yeah, we can hear you. That's good. Thanks, David.
So men of sex with men were identified as being a particular risk for the negative impact of this outbreak. So that included unmet health needs, perhaps reduced access to healthcare services as a consequence of this outbreak. It included stigma, discrimination, so maybe from both, who actually contracted Mpox and were experiencing stigma or discrimination as a consequence of that, but also men of sex with men generally experience some stigma from other groups just by nature of this illness being primarily affecting men of sex with men. Also issues with employment, so potentially people having to isolate, and the isolation period for Mpox is quite long. Reduced access to education, and then potentially social isolation. So that would be both from actually having to isolate because of Mpox, but also, potentially having to reduce your contacts in order to try and prevent yourself from contracting Mpox from others. So following that and following this understanding that men of sex with men were likely going to be particularly affected by this outbreak, we had 3 research questions. So the first one is on thoughts and concerns of men of sex with men in Ireland on the prevention, experience, and aftermath of Mpox. The second one was the impact of Mpox on the daily lives of men of sex with men in Ireland. And then the third one was community preferences and the types of support and information. We centered our recommendations around those research questions as well. So briefly, our methods, we had an online open-ended survey. So we distributed this through social media. So like Grindr, went through GCN. And we were just looking to elicit the experiences of any men in Ireland aged over 18 who had sex with other men. Data collection for this started in December 2022 and ran to the middle of January 2023. And you can see an example of the type of postering. So that poster would have been shared on social media. It was quite a general call to just get people's thoughts on Mpox. We ended up with 163 people, which is quite a lot for, I guess, a qualitative survey. They were aged 18 to 68. They all identified as male. And as you can see there, that 163 were primarily made up of people who described themselves as being Irish and gay. More than half of them were based in Dublin. Most of them were degree holders. They tended to be of a high income. And 97% of them had no Mpox diagnosis. So had 163 participants, but only 5 of those people actually had Mpox. So as a consequence, you might want to think about that when hearing about the experiences of people who actually had Mpox, that we weren't able to actually recruit many for the study. Participants were given plain language overview of the study, consent, and they were basically asked open-ended questions. So general questions, they had text boxes. They were given kind of prompts for what they could say, but it wasn't very prescriptive. And then there's also a couple of closed questions, so just people answering on scales. So we just kind of summarized those quantitative questions, those scale questions, to analyze the qualitative data. We took a critical realist orientation, and we used a socio-ecological model. So essentially just understanding that Mpox operated across individual, interpersonal, community, and structural levels. And also that people's experiences were likely to change across time. So there was also a temporal aspect to how we understood this data. And we use reflexive thematic analysis to generate our analytic themes. So just briefly, the quantitative results. So this is what we had from like the scales that we used. So generally, people had kind of a moderate concern about contracting Mpox and a moderate perceived risk of contracting Mpox. This was lower than for other STIs, which is probably reflective of reality that even during the height of this outbreak, people were still more likely to contract other STIs than they were to contract Mpox. People had a relatively high perceived negative impact of Mpox infection. And then those 5 people who were actually had experience of having Mpox, they reported the impact as a little lower than that. People felt moderately informed about the public health emergency and felt that they, to some extent, understood the public health guidance. People looked to lots of different sources for information on Mpox, but the biggest one were Irish community organisations. So almost 2/3 of participants that responded to this went to Irish community organisations to get information about Mpox, which I think is something really interesting to consider. We also had a lot of people getting information from hookup and dating apps, so that might have been through like targeted advertisements about Mpox, but it could also have been actually talking to other community members on those apps. And then Irish government sources were also a big resource for people. Over 40% of people looked to those as well. Perceived trustworthiness of resources. So right at the bottom, we have different social media. So people didn't put a lot of faith in particularly Facebook posts, TikTok posts, Instagram and Twitter were more trustworthy. And then right at the top, you have Irish community organisations. So they were actually just marginally, they were reported as being more trustworthy than healthcare providers as sexual health clinics. So they were both very well trusted. And slightly lower, you have healthcare providers at hospitals and Irish government sources. That was kind of our quantitative overview, but we were really interested in the qualitative experiences that people had. And because of that, we developed 4 teams based on the responses that people gave us. So the first one is around we kind of centered it on perceptions of the Mpox response, and particularly on this divergence in urgency, priority, and care between what people perceived as statutory bodies and then community organizations, and the difference that people perceived in those responses. The second theme is around the Mpox outbreak as a sign of otherness for men of sex men. So particularly in relation to maybe how men of sex men felt they were treated by society more broadly and treated by the government and that sort of thing. A third theme was around othering through Mpox prevention practices. And this was particularly relevant for intra-community experiences. So how men felt they were maybe treated by other men of sex men. And then our final theme centered on this fear that people had of Mpox and also a bit on the influence of previous culturally significant pandemics. So in particular, that would have been HIV/AIDS and COVID-19. So this is our first theme around the differences in responses, I suppose, between maybe statutory organizations and community organizations. And in particular, you had people kind of feeling that there was some injustice around the way that men of sex men were treated, particularly in relation to the government. So this was like, there's no doubt there would have been very different if it wasn't the LGBT community being mostly impacted by it. This idea that because this was an illness specifically affecting men of sex men, that maybe they weren't being given fair treatment or weren't being given the same treatment they would have been given if they belonged to a different group. This, I suppose some people felt that it was just that was the way it is, and this was a new outbreak and something difficult to respond to. But some people did feel quite strongly that it was specifically because of their identity. And the government response was contrasted with international responses. So particularly in maybe France or in America, where people saw vaccine rollouts happening much faster than they happened in Ireland. And people thought that was reflective of the government's care and attendance to men out of sex and men here. And that was really interesting because it was contrasted quite strongly with the really positive role that people thought community organizations were playing. So someone said, like, local groups, especially in the LGBT community, are doing Trojan work. This should be a government-led response to what's supposed to be a public health emergency. So there was this idea that these community organizations were being very visible and very helpful, but that people didn't really know or weren't sure if the groups that maybe they thought should be responsible for this were actually acting. Our second theme was around the Mpox outbreak as a sign of othering from men who have sex with men. So we had one participant who said they felt it had been portrayed in Ireland as another gay plague. And a lot of participants, not all of them, but a lot of them resisted this idea that Mpox was maybe, unfairly tied to men who have sex with men, or that people took some issue with public health messaging where it was linked to men who have sex with men. It's also the other side of that, where some people thought it was important to have community-specific messaging. But this idea that, because this was a gay disease, or, as this participant described it, a gay plague, people were very concerned about how people might think of them as a consequence. So someone said, I'm becoming more paranoid of judgments based around Mpox that others may make of me if I openly disclose my orientation to new people. So this wasn't specifically about contracting Mpox. It was just this idea that because this participant was gay, that they might be mistreated because of this association between, sleeping with men and contracting Mpox. There was also this idea that contracting Mpox would maybe expose someone's sexual history or sexual activity. So someone said, if I were to get Mpox, I felt my sexual activity would be exposed and I would be embarrassed. And we saw this also with people trying to avail of treatment who were maybe unwilling to go to clinics because they were worried that it would, open their identity up to scrutiny. A third result is more specifically within communities of men who have sex with men. So this is the potential for othering within communities, but it was particularly enacted through prevention practices. And we had maybe a lot of, competition and tension between community members in terms of how they perceived the response to this outbreak. So you had one participant in Kerry saying the gay saunas in Dublin should be shut down on public health grounds, given that every friend and friend of friends seems to regularly contract STIs in them. So this idea that maybe some community members were acting in a way that was, safer or more helpful than others. And this kind of policing of behavior, I guess, that there was one way to act responsibly in response to, the Mpox outbreak, that some people weren't doing that. You had participants engaging in kind of something similar to serosorting for HIV, whereby they said, early on, I was definitely less likely to hook up with guys I didn't know well to help reduce my risk of getting Mpox. So that's, potentially making quite arbitrary judgments about maybe what you expect someone's sexual history to be, how likely you expect them to have Mpox, and then choosing to sleep with them or not sleep with them based on that criteria. And you also had a particular competition around vaccines. So someone saying the vaccines had to be prioritized to highest risk, but this indirectly punished those who actively chose to lower their risk exposure until the vaccine was available. And another participant saying you must identify as a slut to get the vaccine. So it's this idea that, people maybe who weren't adhering to this idea of being a responsible member of the community were then being rewarded by getting the vaccine. And the people who weren't doing that were being punished because they weren't engaging in something that they considered high risk. And it really pitted people against each other in this way. And I think that's particularly something that we note in our recommendations, that the manner in which the vaccine was prioritized and the criteria for doing that may not have been helpful in terms of how people understood the behavior of other community members and how they framed that. And then our last result focuses on the fear that people had of Mpox, and particularly how that was influenced by other culturally significant pandemics. So people had kind of, quite scary images of Mpox described to them. Some people also saw these images online, maybe, of sores or lesions. One participant said a close friend described it as an excruciatingly painful experience. This really made me fearful. And this fear of contracting it wasn't just limited to, those men themselves. It was also fear about giving it to other family members, giving it to other people in their community. And people got, I guess, quite paranoid about this, paranoid about the consequences of it. So someone said, I'm looking at people's bodies and can't relax during sex. And there was this idea that, potentially contracting Mpox would have a massive impact on your life. And one participant who did have Mpox said that, this was true, that they didn't have anyone to talk to about it, except one family member who called them every day during the isolation. It was a lonely and difficult period. And so people were very scared of this and very scared of giving it to others. And this kind of fell onto a backdrop of, other culturally significant pandemics, and in particular for men who have sex with men, that would be HIV. So a lot of people made these comparisons between Mpox as being this maybe new gay disease, and this idea that, we had been through this before. One participant said, the Irish gay community is already so fragile. I really don't want this to be another AIDS crisis. I don't think my poor heart could take it. And lots of people made those comparisons between what they had experienced before, and this idea that it was history repeating itself in some way. People also talked about COVID in that context. So, participants were talking about the fact that maybe other communities were, just coming out of the COVID-19 pandemic. They were returning back to life as normal, or life as it had been before. And gay communities weren't able to do that because they had this outbreak of Mpox that they had to deal with. So following those, 4 themes that we developed, we made a series of recommendations, and we centered those around the research questions that we had based the research on to start with. So the first one is around thoughts and concerns of men who have sex with men in Ireland on the prevention, experience, and aftermath. And the first recommendation we had for that was to develop and publish a co-produced LGBT health strategy to demonstrate the needs of GBMSM and others within the LGBT community are recognised and prioritised. So this was really following on from this idea that men who have sex with men maybe perceive themselves as not being prioritised through this outbreak. And also, I guess, people had existing maybe perceptions of institutional homophobia. And as such, the government response, strengthened those perceptions that they already had, and it wasn't really helpful. Our second recommendation is to consider targeted public health interventions and awareness campaigns for men who have sex with men and for other relevant public health issues. So in this study, we saw a lot of eagerness for vaccination. Men who have sex with men in Ireland have, demonstrated themselves to be vaccine ready. They, adhered to and supported public health measures very well. They went to a lot of effort to try and protect their community and protect other communities. So that could be something that's, worth considering in future campaigns. We also suggest that we have increased sustainable investment in sexual health and public health infrastructure that responds to a situation like the Mpox outbreak and provides support to the community sector. So this is just in relation to resourcing, I guess. And I think something that particularly shown here was the experience of people in rural communities. So you had one participant saying that they had to drive 3 hours each way to access an Mpox vaccine. So someone doing a 6-hour round journey in order to access sexual health care, particularly in the context of where, they were maybe experiencing other challenges around this community-specific outbreak, to put that additional burden on people. Really, people were not happy with the public health infrastructure that was afforded to them. Our fourth recommendation is to undertake diversity, equality, and inclusion audits of vaccine delivery programs in relevant state bodies to ensure they address rather than reinforce pre-existing stigma. So I guess the early prioritization that we had around, who could access these vaccines led to kind of stigmatization of those groups that were prioritized. And I think the criteria also created, significant tension between men who have sex with men who may be considered themselves as engaging in less risky behavior than others, and maybe felt that they should be rewarded in some way. But those criteria caused a lot of stigma and issues for this community. And it's something to consider when you're implementing those kind of programs in future. So our second set of recommendations then relate to the impact of Mpox on the daily lives of men who have sex with men. So one of our recommendations is to conduct further research with those who were diagnosed with Mpox to actually understand how this did impact their lived experience. As I said, we only had 5 people with Mpox in this study, and while we can, make some claims around them, we really need to, explore that population specifically to see what experiences and needs they had. We're also recommending that we provide training in sex-positive patient-provider communication for healthcare practitioners in general practice, sexual health, and public health. So a lot of people described maybe negative experiences with healthcare practitioners, people who, felt that they weren't being provided with, I guess, culturally appropriate care, and this idea that maybe some people didn't understand the experiences that they were having. Some people were being asked questions that they didn't think they should be asked. Our third recommendation in this section is to provide greater supports for self-isolation. And this was particularly, I guess, contrasted with COVID-19, where people who had COVID were provided with financial support, but people who had Mpox weren't. And this was seen as another example of maybe institutional homophobia, where other communities were being supported through a pandemic, but men of sex and men were not. And that lack of financial support was also a really big source of anxiety for men who didn't have Mpox. So even though they didn't actually have it, they were really concerned about getting it because, having to take time off work, and how would they afford that? Our next recommendation is holistic healthcare services for men of sex and men. Excuse me. So I guess that's to do with kind of the intersection between mental and physical aspects of sexual health. For men of sex with men, that they have quite specific needs, and particularly given people's experiences attempting to maybe embed themselves in care that perhaps isn't suitable for them, and presents significant challenges for the community. And then the last recommendation for this section is to develop strategies for supporting peer-led initiatives for communication, information, support in statutory public health organizations and community organizations in response to disease outbreaks that affect their communities. So this is this idea that, the role that community organizations and peer-led initiatives played were really helpful. We saw, the community really did a lot to look after itself. And we had lots of people, saying that they were reaching out to their friends and reaching out to others and making sure that people were aware of vaccines and aware of, case rates, and were really up to date on what was going on. And that sort of peer support was really important for people. And having, public health organizations and community organizations supporting these communities and helping them to engage in these kind of initiatives is also really important. And then our final set of recommendations relates to the type of support and information provision that people got on Mpox. And our first recommendation there is to continue the partnership between community organizations and statutory public health agencies, but crucially with enhanced visibility of those public health agencies. So as Ireland, I guess, conceived an approach to Mpox, it was decided to centre those community organisations at the head of the public health response in terms of, communication with those affected. And that was really successful. And we saw that people were really happy with the support provided them by the likes of Empower and Man to Man, and other community organisations were really frequently praised. But I think people maybe weren't aware that that represented an intentional decision by health services to let these community organizations lead on this, or to hand the reins over to community organizations. So that partnership was really effective in terms of information provision, and Ireland had a really great international response to Mpox. But I guess in future, it will be important to make sure that, those public health agencies were still visibly involved with this response, because I guess people didn't perhaps know that those agencies were working behind the scenes, and it was just that the community organizations were leading this public response. And as a result, that maybe damaged trust in these public health agencies because they didn't have that visibility. Next recommendation, to develop mechanisms to co-produce messaging as part of a risk communication and community engagement strategy. And in particular, we're suggesting that you carefully communicate unknowns, uncertainties, and resource constraints rather than be delayed by them. So particularly at the beginning of this outbreak, people felt that someone described it as an information vacuum. This idea that nothing was being communicated. So we had no idea when vaccines will be coming. We had no idea what the risk was. People didn't know maybe how Mpox was transmitted. And there was this kind of overwhelming sense of just that people didn't know what to do because there was no information available. And I think in a lot of cases that was because public health bodies were kind of unsure. This was, quite a new outbreak to us. We didn't necessarily have support readily available for it. But communicating that uncertainty, communicating the fact that we didn't know when vaccines would be available, didn't know how many vaccines there would be, and being open about that would have been a lot more helpful than leaving people in this information vacuum where they just didn't know what was going on. Then we had just ensuring that this risk communication and community engagement strategy includes messaging for the general public designed to tackle stigma when disease outbreaks affect specific communities. So in this case, this kind of reflects people's thoughts that while maybe messaging targeting men and sex men specifically is important in terms of making sure that, they're aware of their specific care needs and aware of specific maybe threats to their health, it was also important to make sure that this didn't, lead to this association between this specific community and this disease outbreak, and that there was specific messaging more broadly for the public to tackle any stigma that might result from that. And then our final recommendation is to maintain surveillance of Mpox cases in countries to which men or sex men in Ireland travel for community events and encourage vaccination against Mpox and other prevention measures. So as Adam said, Mpox has not gone away. And it's really important that we stay aware of, international considerations around new outbreaks and outbreaks in Ireland, and that people continue to be encouraged to get vaccinations and continue to engage in prevention measures. So very briefly, strengths and limitations. It's the first piece of research on the community experiences of Mpox in Ireland, and we had quite a large sample. We had a mixed methods design, and we developed a lot of useful evidence for both this outbreak, but also, new outbreaks, and developed a lot of evidence for, community perceptions of health services for men of sex with men. For this study, we also had a community research advisory group. So they helped to guide us, and I guess they served to kind of triangulate the research that we did. Limitations, we had a cross-sectional design. So we had these one-off responses from participants. They couldn't expand on those responses. It also meant that we couldn't ask them more questions about what they said. The responses were obviously collected over a month period, so they relate to views at that particular time. We may have had sampling biases because of the way that people were recruited. So, for example, 66% of people said that they relied on community organizations for information, but perhaps that was because this survey was shared through community organizations. And also, as I said previously, the sample may represent the views of select subsets of the Irish population. Future research, we need to continue looking at experiences of Mpox, particularly in relation to vaccination, because there's been significant changes in case numbers and the supply of that vaccine. As we made one of our recommendations, we need more research on the experience of those who actually had Mpox. And more generally, we need investigations into the health and well-being needs of men or sex with men and associated health promotion initiatives. And I know that the government has released priorities for research priorities for LGBT communities and also for community delivered care. So hopefully that's something that that can be enacted. Conclusion, I suppose, is just that it's not considered a public health emergency of international concern, but it still did have a significant impact on men and sex men in Ireland. And even if Mpox does not present a significant threat in Ireland, again, we still have massive learnings for future outbreaks of disease and massive learnings for how we interact with men and sex men in public health messaging and in healthcare. The effects of this outbreak are unclear. We don't know how this has affected people's perhaps perception of the health services. We don't know how it's affected how they might perceive new outbreaks. And that's something that we really need to pay attention to when moving forward. So I suppose this research provides insights to inform provision of care for men and sex men during this, but also during future disease outbreaks. So there are some references. Just a thank you to the research advisory group members. So they were really helpful for their expert input throughout in terms of shaping the study and giving feedback. To the HSC, Sexual Health and Crisis Pregnancy Programme, for their continued funding. colleagues and volunteers at Empower and HIV Ireland, especially Adam, who had a massive role in shaping this research. And then all the participants who actually gave us their information and gave us time and energy to participate. So there are contact details there, so feel free to get in touch if you have the questions that don't get addressed today. Thank you.
Thanks so much, David. That was a really excellent presentation on the findings and recommendations. Lots in there to discuss, and the sound picked up perfectly afterwards. So you might still want to invest in a Brittany headset like this.
Yeah, perhaps.
But look, we'll kick off our discussion by inviting, well, we have John and Chris with us. Dr. Chris Noon comes from the School of Psychology at the University of Galway, and Dr. John Gilmore from the School of Nursing, Midwifery and Health Systems at UCD. So folks watching live, if you do have any questions or comments for the research team, please do fire them into the comments section and the chat box on whatever platform that you're watching on, and we'll get to them. David, I'll give you a little break from talking for a few moments, and I might start with you, Chris. In a lot of the respondents' comments, the kind of the theme of stigma was really evident, perceived stigma or enacted stigma, as we saw from the kind of results on othering. Can you maybe speak to us a little bit about the different ways you think stigma shaped the impact of Mpox?
Sure. Yeah, it was a very strong theme throughout the research, and I suppose something about Mpox is that it triggers various different types of stigma. So there's Carmen Logie talks about different types of stigma that can affect health conditions, and that there can be stigma associated with health conditions that are associated with a specific kind of foreign other. So we had that with COVID-19, increasing racism against Asian communities, and Mpox has that characteristic of coming from or originating in a specific place, and there's there was the potential for racism associated with that. There are some survey studies that have shown that people perceive Black people to be more likely to have Mpox than white people or people of other racial backgrounds. But I suppose you can also think about the foreign other. Gay and bi men in a way are foreign to the overall population. They're considered, they're still, while attitudes have become much more positive, there's still something distinctive and different about us, and that feeds into this idea of Mpox becoming, that you saw the comment that David highlighted from one of our participants who was worrying about Mpox being another gay disease, and then just the fact that it was associated with sex as well ties into this other source of stigma of when there's any sort of, that Logie talks about, the immoral other, or the othering people who in some sense violate moral norms in society. And because Mpox is associated with sex, and because of we know part of the ways that it transmitted were to do with to do with, there was a debate about whether it even was a sexually transmitted disease or not at the start of the outbreak, but that said more about people being uncomfortable with it being related to sex than it did about it being useful to distinguish it as a sexually transmitted disease or not. And in fact, there was many good reasons to acknowledge the sexual nature of it, so that the people with the right types of resources and skills could address it. And then the last kind of stigma that can affect health conditions is like the visibility of a health condition. And I suppose this was something that distinguished that was different between Mpox and COVID-19, but does kind of echo the experiences of people at the height of the AIDS crisis, that when Kaposi's sarcoma would have been seen as a visible marker of AIDS. Similarly with Mpox, there's the skin lesions associated with it evoke a very stigmatizing response in others. So you have all three of these different types of sources of stigma combining in one in one health condition when it came to Mpox, and then that was exacerbated by some of the some of the strategies for prevention that especially if we look at the vaccination program and how people got access to that at the start based on having had a syphilis previous experience of syphilis, and that really added another source of stigma to the mix. So figuring out ways of addressing these sources of stigma is absolutely crucial going forward. I don't and there's lots of ways that we can learn from past we've drawn parallels with HIV and COVID there, and we need to learn from past experiences with those. We need to learn from the last year and a half of or so of Mpox to try and develop better strategies for preventing stigma from 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 being a barrier to addressing outbreaks like this.
And really important, I suppose, then that we have within that set of recommendations, identifying the need to research those with lived experience, so that we can, have a first-hand account of what how stigma was enacted or felt or perceived. So hopefully that'll be, maybe that's a 2024 project. John, I'll come to you. The report kind of carries a fairly comprehensive set of recommendations. Can you talk to us a bit about what you reckon the research might mean for, health service policy and healthcare provision, maybe generally, but also for GBMSM?
Thanks, Adam. Hopefully my sound is okay. I think one of the things, while this was a cross-sectional survey of gay and bi men and other men-of-sex men at a certain point focused on Mpox, I think through our analysis we were getting a lot of insight into the wider attitudes and experiences of healthcare and health service provision and strategy from the community. And David quite articulately put forward that kind of tension between people feeling very, very well supported by the community organisations and in some ways let down by the statutory and public health agencies and organisations. Although we know that was a strategy of the statutory organisations. So there was this tension, and we're not suggesting, I think, in our research that people should thanking people is the most important thing, but actually it's deeper than that, and looking at what impact, if people have ongoing perceptions of discrimination, of exclusion, of institutionalized homophobia, okay, in this instance, they received the information they needed from the community organizations, but in the future, how will that impact health-seeking behaviors? How will that impact other issues in public health? And throughout the research, we've also talked about, what we were getting, again, at a period of time, was this kind of willingness for gay and bi men to engage in public health messaging, to get vaccinated, and how can we think about leveraging that within other kind of public health and health provision measures? I think what we know is that the community in this instance felt well supported by the community organizations, but also that informal community engagement and community support and peer support amongst each other. And I think for me, and focusing on other work I'm doing, it again and again is highlighting the need not only for community organizations in the health protection and health promotion sphere, like the Empower program, but actually community-led health service provision is really important. So I think that's, coming from our recommendation around LGBTQI plus healthcare in the community, by the community, and exploring how that can be delivered in an Irish context. I think we have a great opportunity now with Sláinte Care and a focus on communities and a focus on delivering healthcare in the community. And I think thinking about ourselves as LGBTQI plus people, and specifically around gay and bi men, and thinking about that holistic health need. So in encouraging our activists in the community and our community organizations to continue to advocate for that and the important voice of people with lived experience in that.
Yeah, it's interesting that you say about that, the importance of that kind of relying on one another as community members, and as that being an important part. And during the outbreak, we stood up a counselling service for people either that have lived experience of Mpox and were living through it, or were kind of affected by the environment of it all. And uptake was actually quite low of the service. And what we were hearing more and more was a real reliance on community, on their friends and their lovers. So yeah, I think there's a wealth to be tapped into within our own community. David, you've probably had a little sip of water from ready for a question. I guess maybe standing back from the research now, what would you say is kind of the most important finding, or maybe a key lesson to be learned from the research?
I suppose I think, like as John kind of suggested, that while this is a snapshot in time, it's a really important study in terms of understanding more generally how men might interact with healthcare systems in Ireland in the future, but also a lot of the stuff that people saw, they were highlighted by Mpox, but these problems aren't caused by Mpox. So for example, these people engaging with healthcare services who feel that maybe sexual healthcare staff have heteronormative understandings of their sex life, or don't really understand the type of sex they're having. That's not caused by Mpox, and it was particularly highlighted here. But I think this, taking a step back from this research, if you want to do it in that way, it's important to understand that this is just highlighting ongoing issues that we have with the delivery of care to men who have sex with men. And it's much more general than just looking at this through the lens of Mpox, or even just looking at it through the lens of this isolated outbreak of disease. It's an ongoing understanding that we need to have better healthcare and support services for these men, generally in our system.
Great, thanks, David. I'm looking, there doesn't seem to be any questions in the comment sections that I can see. I don't know if there are any final comments that any of the team there want to make. No, if not, well, we're stealing people's lunch hour. So what I might do is just thank you all, David, Chris, and John, for your input today and throughout the study. And it's a really valuable piece of research, and I look forward to continuing to work with you. A very special thanks as well to, we do have a question, do we? Last minute. From Carl. I was just going to ask if the experience of service users at sexual health clinics was touched on, and what needs to happen to address that.
I mean, there were comments about the experience of people who had been to sexual health clinics, that from the very small number of people who had experienced Mpox. I think the majority of the comments were quite positive, that they felt like they were looked after very well, and kept in touch with. So yeah, on the other side of things, there were other aspects of their care that were more difficult, like the isolation. Some people having to self-isolate in facilities, other like that, and not being able to do it at home. But that wasn't part of the experience of the sexual health clinic per se.
Thanks, Chris. And thanks, Carl. Sorry, were you going to jump in there, John?
Yeah, I might just say as well, I think one of the things, and David highlighted this, that some of our participants who are living rurally highlighted kind of that. And I think what we've seen in Ireland, we've seen quite significant expansion of sexual health services in Ireland in many different ways, which is really welcome and really positive. And we now have postal testing, online testing. We have community organisations, both in Dublin and outside of Dublin, doing rapid HIV testing. And there's been a huge amount of focus, but that doesn't mean we don't need more. And I suppose what we saw with Mpox, there was a lot of anxiety and fear, and this was something new and novel and needed to be services needed to be adaptable and in the response. And I think for that reason, it's about ensuring that we continue to build that capacity within sexual health services. I think remembering as well, one thing that I thought when we were doing the research was one of the valuable things from talking to the clinicians who are working in the field would have been actually understanding what this meant for sexual health care providers. I mean, I'm a clinician myself, but talking to sexual health care providers, because by and large, sexual health in Ireland is provided through infectious diseases services, who were the lead kind of deliverers of COVID-19 services. It was just kind of getting over that maybe, or managing that. We've had an ongoing syphilis kind of high rates. There's a lot of strain and stress. So I think, we're not always aware of that in the community, at the amount of strain that's on the service. And we're quite quick to complain that we can't get an appointment straight away, or the services isn't accessed. So I think coming together and partnering, like the partnering between the health services and the community organisations, actually the community coming behind the services, again, to advocate for further resources and more appropriate resources. But it was really positive, and I think we see that when we engage, and Adam, you probably see it with your peer outreach. People in general have quite a positive experience of sexual health service in Ireland. Now, that's not universal. We always hear stories back of individual cases, but I think overall people do feel well cared for. So it's about supporting those services to expand and continue to do the really important work. And again, beyond sexually acquired infections and HIV, actually supporting people to have good sex and lots of it if they want to.
Absolutely. And yeah, just to echo that, I think when we started promoting just earlier in the week, promoting this event, I got a message from a sexual health nurse saying, I'm not sure if I'm ready to hear what the community thinks about us. And I said, well, it's really not that bad. It's not bad at all. I think our community really, really value the dedication of the vast majority of sexual health service staff, and recognize that there are systems within that they have to work within systems and the capacity within those systems. And it's definitely, when I had worked at the Gay Men's Health Service, it was something that was overwhelming, the amount of thanks that came to sexual health service staff. So we do love yous. So on that, again, just a thanks to the research team for all their input. A very special thanks to Alice, Stefano, and Michael at GCN for all of their fantastic support in delivering this event. It's a really slick operation. And a big thanks to our research advisory group, the HSE Sexual Health and Crisis Pregnancy Programme, and the Mpox National Crisis Management Team for the funding of the research, but also their continued support of our work at Empower. A very special thank you to the Empower team and our volunteers for all of their really dedicated hard work always, but particularly during the Mpox outbreak. Thanks to our colleagues at HIV Ireland too, and I saw Freddie is tweeting up a storm there as well. So thanks for that. And most importantly, to all of the gay and bi men across the country for responding really generously and sharing your views. A reminder again that the Mpox report is available on our website under the research section on the Empower website. And finally, just thank you for tuning in, and thank you for taking part. get vaccinated, and have a wonderful weekend. Thank you.